everybody, and welcome to the Daiwa Anglo-Japanese Foundation. My name is Jason James. I'm chairing today. Right, so I'm in London, as I mentioned, and we have two speakers today, one of whom is in Tokyo and the other is in Amsterdam, and I will just introduce the two of them briefly. So Dr. Osamu Kunii is Head of Strategy, Investment and Impact Division at the Global Fund. He has a very wide-ranging career as a clinician and humanitarian worker for NGOs, then in public health. He was Assistant Director at the Japanese Ministry of Foreign Affairs and also Senior Health Strategy Advisor at UNICEF headquarters, Assistant Professor of International Health, University of Tokyo, and Professor of Global Health in the Institute of Tropical Medicine, Nagasaki. And in fact, both of our speakers have been around quite a bit geographically speaking. So moving on, our second speaker is Dr. Stuart Blume, and he is Emeritus Professor of Science and Technology Studies at the University of Amsterdam, and is the author of this book, Immunization, How Vaccines Became Controversial. So that's clearly a relevant topic today. And he has worked at the University of Sussex, at the OECD in Paris, and in various parts of the UK government, including the Cabinet Office and the Committee on Social Inequalities in Health. And he has been an advisor to the World Federation of the Deaf and a visiting researcher at various universities. So I'll just show you the timeline briefly. That was my introduction. We'll have about 15 minutes from each speaker, and then we'll open it up for Q&A. So over to you, Dr. Kunii.
Good morning, good afternoon, and good evening, everyone. Today I'm going to talk about some of the recent trend of the COVID-19 epidemics, and also kind of situation, and also a global collaboration, especially highlighting ACTA-A, and some of the opportunities and challenges. Okay, slide please. So this COVID pandemic really brought that number. Okay, first slide. Okay, next slide please. Yes. So this COVID-19 pandemic really brought that, confirmed total cases 44 million and total deaths 1.1 million. And you can see in its slides, daily cases and daily deaths are still increasing, and especially in these, 1 or 2 weeks. Next slide, please. And actually, the top cause of death among infectious diseases, tuberculosis still. It's account for 1.5 million deaths per year. But this COVID is maybe catching up, and maybe it will exceed quite soon. But the daily deaths is now the COVID-19 is most, sometimes more than 5,000. And actually, in the past, tuberculosis, HIV, malaria, we call that the three, the killers or three biggest diseases, infectious diseases, killed over 15,000 deaths per day. So actually, that the situation 10 years ago or 20 years ago were very, very serious. But now this COVID-19 came and showed that the first cause of death now in daily one. Next slide, please. Next slide, please. Okay, so this is the infographic showing that the increase of cases, recent one. So average, percent change in a week. So right side, the red one are countries in increase of these cases. Many European countries, Asia, and others. And left side are decrease, countries in decrease, but quite, not so many countries. Okay, next slide, please. Of course, COVID-19 is very dreadful and scary, but when I actually worked in many countries like South America, Africa, Asia, actually there are many other infectious diseases which are very dreadful, scary. In terms of case fatality rate, this is the vertical axis showing the percentage of who die among the cases or infection. So bird flu, Ebola, and the initial stage of HIV actually killed at more than 90% of the cases. So there are many other diseases which have a higher mortality or fatality than COVID. And horizontal axis is this is infectivity, I can say. It's a reproductive number. So how many people are infected by the one of the infected person. So even measles is a very, very dangerous. And when I worked in the refugee camp, if I find one case of measles, it is really dreadful because very, very, in a short term, this spread over the refugee camp and killed so many, under 5 children. But of course, COVID, as a kind of total, it is very dreadful because, it's infect other people without showing any symptom or even before showing that the symptoms. So we can say maybe stealthily, that transmitting. So it's very, very difficult to find these cases. Next, please. Actually, that of course, COVID itself, that the direct, deaths also many, but at the same time, the COVID has an indirect effect, negative effect on other diseases, so because of a disruption of so many services. So while I'm working for 3 diseases, fighting for 3 diseases, we found a lot of disruption of services of 3 diseases. So according to that mathematical model, we see that almost, a number of deaths of HIV, TB, malaria would be double next year. So it would be a very, very big, indirect effect. Next slide, please. And actually, it is not only just a mathematical model, but we are doing weekly or bi-weekly monitoring, and we found that a lot of disruption cases on the ground. So this is a graph of in Philippines, COVID-19 impact that the services of detecting and diagnosing that TB, tuberculosis cases. So it become 1/6 of the cases are missing now. So it is a quite big, the indirect effect. Next slide, please. Okay, so now we are making so much effort and making global collaboration. It is really kind of innovative. Of course, in the past we had a lot of collaboration, but this is maybe first ever, I can say. Many international organizations, academia, the public and private sectors also supporting this access to COVID-19 tools. ACT accelerator, we call ACTA. And we set 3 pillars: vaccines, therapeutics, and diagnostics. And led by the vaccine pillars is led by CEPI and Gavi. Therapeutics led by United and Wellcome Trust. Diagnostics led by us, Global Fund, and FIND. And we set the targets like 2 billion of people would be vaccinated by the end of 2021 in the world. And the therapeutics, effective therapeutics would be developed and provided to 245 million people in the world, especially the low and middle income countries by mid-2021. And the diagnostics, effective, high quality one, to be provided to 500 million actually testing. And these 3 pillars are connected by the health system connectors, also led by Global Fund and the World Bank. Next slide, please. And we need a variety of steps. Next slide, please, for this kind of collaboration, because we first need to assess the situation. So we start with situation analysis. Next slide, please. Situation analysis, needs assessment, and initially we use a model, but gradually we are using the real data. But anyway, based on those data, we develop investment cases, which set the target, common goals and target, and some indicators and cost analysis. And based on that investment case, we mobilize resources. So currently we target 38 billion US dollar for more than 100 low and middle income countries to provide these three pillars of tools to end or suppress this COVID-19. But unfortunately, we got only pledged 4 billion, meaning 1/10 of target is now filled, and 9/10 of these targets are still gap. And can you imagine OECD countries, rich countries, already deployed 10 trillion US dollars for financial measures. So even this 38 billion means that almost 3% or less than that, around that. But they, 4 billion is a very, very limited number of money, I can say. But unfortunately, we couldn't get that kind of resource mobilization so far. And we support and facilitate R&D, research and development. And more than the R&D itself, we need to be prepared for mass production and allocation and a very swift distribution of those tools to many countries. And of course, monitoring and evaluation we have to do. Next slide, please. And so maybe vaccine would be covered by Dr. Blume. So I will just give an example of the ACTA-A, the diagnostic pillars. So far, we provided millions of molecular tests, the PCR. As you know, this requires a very highly skilled people. So we provided the automated molecular test, automatically, that analyze. And fortunately, we Global Fund provided a lot of automated PCR test machines to many low and middle income countries because it could be used for tuberculosis. So fortunately, we could use those machines for COVID testing because some of the companies developed that cartridge for COVID-19. So initially, we started to distribute those cartridge to many countries. But now, the more needed for the rapid diagnostic test, because we need to make this kind of testing at point of care, the use. So we expected and we facilitated this diagnostics test. And finally, we got 2 products of antigen-based rapid diagnostic test in WHO's essential the emergency use of list. So we provided the 50 million US dollar for initial procurement fund from Global Fund. And we now planning to distribute very rapidly 120 million cases, the testing. And it's very rapid testing, only 15 to 30 minutes per test, and very inexpensive. The Gates Foundation also provided kind of support for this kind of matching fundings. And we suppressed the price, unit price, up to the $5 per test. Yeah, so, and Global Fund, African CDC, Gates Foundation, Clinton Health Access Initiative, many, the international organization and foundation supporting this pillar. Next slide, please. Actually, this COVID, we cannot wait for budget. As I said, only 1/10 of our targets is pledged. So we use our own money, the Global Fund money, because our funding are already at the country level. So we asked that the countries which needs at the COVID response to reprogram or repurpose that our 3 disease the programming, because as I said, this COVID really disrupted the 3 disease programming. So they try to save some of the money and mobilize those resources for rapid and the flexible and at scale support. So finally, we kind of saved and raised funding for up to $1 billion for 100 countries. We already approved reviewed and approved this grant flexibility, reprogramming, and new funding from saving and the new money also provided to 100 countries. So, and it is very quick, only just 3 days of turnaround for this flexibility and 10 days for this new money, the application. So we could respond very, very quickly and in an agile way. And what kind of services we are supporting? We are supporting for testing, tracing, isolation services. So we provided support for training, especially for the infection prevention of lab or health workers. And we provided PPE, personal protective equipments, diagnostics, therapeutics. Nowadays, that dexamethasone is quite effective for the patient in a quite serious status. So we are also supporting those. And we improved the procurement mechanism of procurement is we purchase those supplies in huge amounts so that we could reduce unit cost, and we could massively distribute to many countries. And finally, we have quite added value. Global Fund is quite known as a 21st century innovative partnership organization. So we have a lot of good networking, especially with NGOs, civil societies, community-based organizations. So they are really working for COVID response as well. And key populations, societies also supporting themselves and also monitoring and supporting services. Because as you know, top-down approach sometimes miss the real, the behavior change or adherence to isolation or social distancing. So a community or peer could support each other and try to make effective adherence and isolation and social distancing. Okay, I want to stop there. And okay, finally, this is final slides. Okay, I want to say this COVID is also a kind of good opportunity to turn crisis into chance, because we found that really kind of innovative things, global efforts and collaborations is, I can say, really kind of massive and very amazing. And not only just R&D, because, in the past, we called it neglected tropical diseases, because, these tropical diseases or communicable diseases could be, our spent very little amount of, budget for R&D and the services, because, as you know, market failure, the people, living in tropical diseases, tropical areas, could not pay for those, expensive diagnostics or therapeutics. So, naturally, that private sectors have a very low incentive, to develop those new products. That is why, even TB, tuberculosis, the new drug were very recently developed, but it is 40 years after the last one. So you can understand that how that the low budget and efforts are given to neglected tropical diseases. Even now, only less than 0.5% of the pipelines of the products are for these communicable diseases. Over 90% are chronic diseases or lifestyle diseases. So it's a really kind of disproportionately allocated. And the data, you can imagine, nowadays we have a very great real-time of monitoring. You can see deaths and the cases every day. But usually even HIV, TB, malaria, these reports are just 1 year before. That usually that we can get the data 1 or 2 years before. So we found that, okay, we can do that, even real-time monitoring is easy. And we can do like kind of a data sharing and analysis synthesis by, many other people. So many, the academia, even civil people could support, visualization, analysis, synthesis of data. And even other field, we are now catching up with, HIV, TB, malaria, other diseases. So we are now accelerating our effort on these diseases. For example, we are accelerating self-testing of HIV because, health workers are are, very much limited in resources. So we are promoting health self-testing, and even service delivery. We are promoting multi-month dispensary or community-based, approaches. And as you know, ICT, information communication technologies, is very much advanced and applied in the field, and even in Africa. So digital health or remote or e-health, whatever we call it's a very, very great chance, to introduce or scale up, not only for COVID, but for other diseases. Okay, I want to stop here, and thank you very much. Over to Professor Blume.
Yeah, thank you very much.
One of the few gratifying aspects of our current situation, certainly for anyone interested in the history of vaccines, is the astonishing progress that's been made in attempting to develop an effective vaccine. Today, there are, normally development of a new vaccine takes 5, 6, 7, 8 years. Today, in 9 months, we've got to a position in which there are something like 200 candidate vaccines under development, of which more than 40 are being tested on people in clinical trials. And of those, 10 are already in the very last stage of clinical testing, the so-called phase 3 trials. This is a speed of progress unparalleled in history. I'm not going to talk about the challenges that the scientists and the virologists and the medical professionals have faced. What I want to talk about is the kind of analysis that people like me, historians and social scientists, can make, and ask the question in what ways it can be relevant. The starting point, or my starting point, is my belief, that one of our responsibilities as analysts of society is to question things that are taken for granted. Assumptions that we make perhaps almost unwittingly and seem so taken for granted that we don't even think about them or question them or ask why we believe these things. I used to teach I used to give as an example to my students, how do you show to a fish that it's swimming in water? How do you show the water to the fish? So there are things that we assume in acting that we may not be aware we're assuming now. At the start of the pandemic, 8 or 9 months ago, the message that was reiterated constantly by the media and by the politicians in most places, I think, was that when there's a vaccine, everything will be well. We just have to be patient, and it should come quite fast, but when there's a vaccine, it should be possible to return to normal. The question that intrigues me is, why do we believe this? Why did we believe this? We did partly because we wanted to, I as much as anyone. We wanted to hear that. We wanted to see light at the end of the tunnel. But where does this faith in vaccines come from? And what sort of grounds, logical grounds or scientific grounds, do we have for placing so much faith in a vaccine? The fact is that it goes back a lot. Over many decades, we've been led to believe that all infectious disease problems can be made to vanish when there's a vaccine. It's not a new claim. And the fact of the matter is that vaccines have saved millions of lives. That's not at issue. But are we justified necessarily in extrapolating this to the future? How has this faith become so deeply ingrained? And it has become deeply ingrained. You see it reflected in a great deal of popular culture. For example, much quoted these days, the movie Contagion. A problem with placing such considerable faith in a particular technique, and that includes vaccines, a problem with placing so much faith in vaccines in this case is that the risk is of great disappointment. This is not saying that we will be disappointed, it's saying that extreme faith carries with it the risk of extreme disappointment. Now, a study of the history of vaccines and vaccination, for those who ever cared to look into those things, should have shown immediately that there would be problems. Once a vaccine had been developed, there would then be problems of scaling up supply adequately. That's a technical problem, of course. More difficult or a different kind of problem is agreeing and ensuring a fair, equitable distribution of initially limited vaccine supplies, both between countries and within countries, in order to avoid the monopolization of limited supplies by rich countries and social elites. A third issue was the possibility of side effects and the question of responsibility for taking care of those side effects. Now, finally, now these issues are being discussed, though not always in a transparent manner. But we're also seeing now, finally, some discussion of the many aspects of the pandemic that won't be solved by a vaccine, however many antibodies and T cells are produced. Obviously, the economic devastation, growing inequality, and the psychosocial problems due to lack of social contact and what some people call touch deprivation. Now, the question I'd like everybody to think about is, were we, and are we, or have we been ill-prepared to deal with all these, let's say, side effects of the pandemic because we focused so completely and so exclusively and so faithfully on a vaccine? Now, in the second part of what I want to say, it may seem as I'm going to contradict myself, because instead of talking about faith in a vaccine, I want to refocus on people, and there are many of them, who are unsure. What I'd said up till now is the kind of the dominant discourse that has tended to monopolize the mass media and the official messaging. But surveys are now showing that large numbers of people in many countries say they wouldn't accept a vaccine. In some countries, as many as 50%. Now, what lies behind this? It's a familiar question for social scientists because it's the one question that public health authorities have tended to come to social sciences and say, tell us how to get people to see sense. How can we convince people that vaccination is a good thing? It is a good thing. I'm not trying to present an anti-vaccination argument. The problem for a social scientist is that the public health world asking us this question has always been only interested in one kind of answer. It assumes that all those people making misguided decisions are ill-informed, ignorant, or somehow prejudiced. The idea that part of the responsibility may lie in the way, as it were, official institutions work is not acceptable. Nobody wants to hear that. Yet, if we look at the rise of these doubts, anxieties, so what's now called vaccine hesitancy, It starts in the 1980s, and it runs in parallel with, or it grows in parallel with, which of course is not to say there's a causality, it rises in parallel with declining faith in political institutions, the rise of right-wing populism and conspiracy theories, reduction in the accessibility of health services, and a transformation in how and by whom vaccines are produced. There has been something of a decoupling between the people's health concerns and needs and the vaccines that have been produced and introduced into vaccination programs. Many of the vaccines that we've been given over the past 20, 30 years, however good, have not been in response to people's major health concerns. People tended to accept them, but think, yeah, maybe we don't really need it. So, now, I think all of these factors, changes in the legitimacy of political systems, in the accessibility of healthcare, and transformations in the system of vaccine development have contributed. And this all comes now at a time, and these are my last remarks, at a time of declining multilateralism and the rise of what's now called vaccine nationalism, which the WHO is warning us against. If you step back and look at history, you see that at the height of the Cold War, scientists and medical professionals from both sides of the ideological divide were perfectly able to collaborate in developing the polio vaccines, in bringing about the eradication of smallpox. But accompanying that was an attempt on the part of politicians on both sides to turn success in combating disease into an indicator of the ideological superiority of one or other system. It's very complicated. Now we see in some places the idea that being first with a vaccine should say something about the economic and political system which gave rise to it, and should act as a kind of trump card, sorry, the wrong word, a kind of ace in a game. The trouble is, it's not a zero-sum game. We're in a game in which everybody wins or everybody loses. And the real test of the collaborative mechanisms that have been created, I think, is less in the area of creating a vaccine. There will be 2 or 3 vaccines in the next 6 months, that's clear. The real test of the willingness to transcend nationalistic interests is going to be what comes next, distributing it equitably between communities, regaining people's trust, reassuring them that if they do suffer side effects, they won't have to bear the financial consequences. And finally, in finding ways of tackling all the pandemic-related social and mental health issues for which, alas, there never can be a vaccine. Thank you. I'll stop.
Perhaps not. But anyway, I thank you both very much for really interesting presentations. I'm sorry we have to wrap it up because I think the questions started to come thick and fast and we could have gone on for a while. But I really enjoyed it, and that's it for today.